Thank you. Senator Monning.
Thank you, Madam Chair. And first, our congratulations, Ms. Abbott. And,
thank you so much, sir.
And thank you for stepping up to this challenge. It's greatly appreciated. And I won't offer condolences at the same time because you've entered this willingly, but I do applaud your taking this on. The legislation you referred to, I'm the proud author of, and I have had a good working relationship with Secretary Dooley in trying to refocus the role and function of the Office of Patient Advocate. Our original legislation contemplated a central call center, but in the spirit and pragmatics of not creating more bureaucracies, the current system of data gathering from the existing 4 entities you mentioned and is illustrated, that's the path we're pursuing. You mentioned in your comments the challenge that presents because the different agencies, departments collecting data in different ways. And you've given us a bit of an illustration of just some of the preliminary capture of number of complaints and coming in from to the different entities. What I don't see in there, and my question, one of our interests is capturing not just the nature of a complaint, where it came from, some of the demographics of that patient or consumer complaint, but also how it was resolved. Is that going to be part of what you're capturing?
The type of complaint and the resolution and the length of time it takes for that resolution to take place, and that, as you might expect, varies based on the kind of concern that consumer raises and how quickly it can be resolved. But absolutely, I have a spreadsheet that I could unfold for you that is about the size of this table, where we are asking for a lot of information so we can do the outcome analysis that you're asking for, sir.
Great. Well, I appreciate that, and I'll look forward to hearing from some of the public testimony and the healthcare advocates who have also been very instrumental in trying to help gain the right focus here in the capture of very important information with the goal of serving the patients in the consumer community. So thank you, and I'll look forward to the public comment. Thank you, Madam Chair.
Thank you. Finance? LAO? Nothing. Okay, we'll open up to public comment. I'm going to ask members of the public to confine their comments to under 2 minutes, please. Ms. Ma.
Tam Ma with Health Access California. We're here to strongly support the OPA's BCP to implement the Complaint Data Reporting Project. Health Access has had a long history of working to strengthen the consumer assistance hotlines to help Californians navigate the system, exercise their rights, and make informed health care choices. We have sponsored and supported legislation, including Senator Monning's legislation, to revamp the OPA and give it the new responsibility of collecting, tracking, and reporting on data from state health consumer assistance agencies. Having this information will help the state know whether its call centers are or are not helping patients. We also hope that as OPA moves forward in future years, that they'll also include reporting on call center metrics, such as call wait times and drop calls. We believe that call center performance is an important element of consumer complaint handling. Health Access urges your support of this budget item. Thanks so much.
Thank you. Next witness.
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, also in support of the provision, the requested position. We were pleased to work with Senator Monning back in the olden days on AB 922, along with Health Access on the bill. We think the data compilation is very important. We have so many different agencies serving healthcare consumers, so to bring all the data together really gives us a much more comprehensive picture about the experience of healthcare consumers while we're going through such a big transition time. We appreciate that Ms. Abbott sought our feedback about the data compilation process, and we've seen that big spreadsheet, and she was very responsive to our request. So we are our input, so we definitely support the request.
Thank you.
Carrie Sanders with CPEN, also in support of the budget change request for OPA. We supported the legislation to rethink or expand some of the focus of this office and looking at and bringing these reports together. We look forward to working with Ms. Abbott. We're excited about the energy that she brings to the position. We do agree that it can be very confusing. There are many different sites for consumers to go to get information or to file complaints. We look forward to continuing to work with OPA to make it, to make those processes more accessible, particularly to limited English proficient Californians who are, calling and who have issues that they want to report as well. Thanks.
Thank you. And final witness.
Good morning. Members, I'm Gary Passmore with the Congress of California Seniors. I too, our organization, supported then Assemblymember Monning's legislation. We think this is a really critical aspect of all of the enormous health reforms that we've undertaken in California. We would like to see even a more robust Office of Patient Advocate and have the greatest admiration for and confidence in Beth Abbott's ability to make a big difference here. Having a good, clear knowledge of the experiences of the patients as a result of all of our healthcare reforms is going to be critical. It's going to be one of the things that in just a few years you're going to be searching for, and it's important that we set up the systems and that we get it right so that we'll all know how people are experiencing health care in California and what problems they're having, and looking in the data for suggestions for how to resolve problems that are surfacing. So we absolutely support this budget change proposal, and I will hopefully be early in the line up before Rules Committee endorsing Beth Abbott's appointment. Thanks.
Thank you very much. We're going to hold this item open. Thank you very much for your presentation.
Thank you so much.
Appreciate it. We're going to move on to the final item under California Health and Human Services Agency, which is the high-cost drug proposal, page 17 on the committee agenda. Good afternoon.
Good afternoon, Madam Chair and members. My name is Katie Hydorn. I'm Deputy Secretary for the Health and Human Services Agency Special Programs, and I'm here to give you just a high-level market overview as requested in the agenda, and then I'll turn it over to my colleagues from the Department of Finance to go into more detail on the fiscal questions.
Excellent. Thank you.
As you're all aware, in the last year, we've seen specifically 3 very high-cost drugs come on the market that are curative therapies for the hepatitis C virus. Early in the year, over a year ago, we saw Sovaldi, made by Gilead Sciences, come on the market, and most recently, Gilead also produced Harvoni, and AbbVie came on the market with Vicurapac. Just for an example, the market, the addition of additional drug therapies into the market has resulted in one of the manufacturers coming to our Department of Healthcare Services and recently negotiated drug supplemental rebates with on the fee-for-service and the county organized healthcare system markets for both Sovaldi and Harvoni, and we're still in discussions with AbbVie on Vicurapac. We have, as you all know, in response to this, have set forth a work group. We met earlier this week internally with our departments just to do a level-setting meeting. We have been contacted by many stakeholders, many of whom I know are here today and you'll hear from, and we look forward to engaging them hopefully in the next few weeks in a number of discussions. We're looking at both procurement and also clinical practices with regard to all these high-cost drugs. But right now we're focused specifically on hepatitis C. Thanks.
Adam Dorsey, Department of Finance. So start to go through your questions. The first was an overview of the proposal, and I think that my colleague from agency did a very nice job sort of giving you an overview of the proposal. The only thing that I would add is that, we've got thousands of people in the Medi-Cal program, inmates in the correctional system, patients in our state hospitals who are infected with hepatitis C. The cost of these drugs can exceed $80,000 per treatment regimen. And so the idea behind the proposal is to do a $300 million set aside to make sure that we've got enough budgeted in the state budget to account for the cost of these high-cost drugs, and that we, convene the work group that that Ms. Heidorn had mentioned, and so that we can look at utilization of the drugs and protocols for treating people with hepatitis C in these new treatments. The second question was, why does the administration find that a special reserve of general fund is necessary for the state to provide for the cost of these treatments? So while there have been high-cost medical therapies and pharmaceuticals in the past, this situation that we're in is kind of a new challenge in some respects. Again, the cost of the treatments, over $80,000, without a set-aside or a good estimate for each of the department's budgets, we would have been short, and we would have been in a situation where we would have multiple state departments facing significant deficiencies because of these costs. And because these are new drugs, the state has really very little experience. When you looked at, in the Medi-Cal program, for example, in our fee-for-service trend data, because these drugs are so new, when we're building our estimate for that department and for others, very little experience with these drugs. And so because of that, we built in what we knew about what was needed in state departments' budgets, but also tried to, given the rates of infection and the cost of these treatments, provide a set-aside that could be, managed by the administration depending on where we saw utilization increasing, and to the extent that different departments were able to, negotiate rebates and that sort of thing, that would affect the costs, and it would give us the flexibility to make sure that we weren't shorting the budget. The third question is, what was the basis for the $300 million placeholder? The $300 million placeholder is a very rough placeholder, and it was basically based on current protocols and caseloads for individuals infected with hepatitis C in the various programs across state government. But it was very rough, given that the guidelines and the costs for these medications, we knew that they would be changing. The fourth question was, what is the administration's estimate for current year expenditures related to hepatitis C that exceed the Budget Act authority? It's not entirely clear because not all state departments budget at a level of detail and a line item that is detailed enough to pick up certain classes of pharmaceuticals. And so the administration is going to continue to evaluate caseloads, new drugs that are entering the market, the various departments' ability to negotiate rebates, and other factors. And as we learn more, we'll update the budget. The next update will be at the May revision, and we'll update the department budgets, as well as whether there's a need to update the placeholder or continue to carry a placeholder as more information becomes available. I'll take the second part of question 6, which is, does the administration's placeholder funding include consideration of the higher discounts that certain companies are offering in response to more drugs entering the market? So at the time of the governor's budget, Sovaldi was the first drug to enter the market. Mm-hmm. And it was really very difficult for state departments to negotiate rebates at that time. However, we were aware that there were new drugs coming into the market, and we had a policy, and have always had a policy, of aggressively negotiating for rebates where we could. And so we had a placeholder kind of to reflect that uncertainty, that that we've got the caseload, the costs, and the speed with which new drugs were coming to the market, the uncertainty about patient adherence to these new medications, to reinfection rates, and the state's ability to negotiate for rebates. So all of those things were uncertainties, things that we, are still trying to get a handle on. And, as this information kind of becomes more clear over time, we'll be able to update. The seventh question was, why doesn't this proposal include any investments in the prevention of hepatitis C infection, such as providing more access to testing and resources for syringe exchange programs? Mm-hmm. So the governor's budget does not include any new initiatives for hepatitis C prevention. However, the state and our local partners do have a series of existing efforts in place. For example, the Department of Public Health operates a very small office of viral hepatitis prevention. And they work with locals and state and national health officials, community-based organizations, and service providers to reduce the impact of viral hepatitis among adults in California. Many local jurisdictions, so there are 36 jurisdictions that operate needle exchange programs and offer a wide variety of other public health programs across the state. There are existing efforts in place, but we do not have any new proposals in the governor's budget.
And I guess the point of the question was, and why not? Because the pivotal phrase in your response was very small. And given the high costs of the medications as you documented, I guess that's the point of the question. Why aren't we investing more for these populations in prevention?
Yeah, that office, you're absolutely correct, is a very small office, but doing really important work. Mm-hmm. And there are 36 needle exchange programs in many local jurisdictions. There are public health offices in counties across the state.
So is the administration's position that's adequate?
The administration's position is that that's what we've got budgeted right now, and we think that they're doing a very good job and want to continue to support them, and that's what the budget reflects.
And follow up on your second half of answer of question 6. And so since when the budget was developed, it was the one medication, you weren't fully prepared or in a position to negotiate. Should we assume that May revise will reflect kind of a different position?
Well, every iteration of the budget reflects, the best information that we have at the time, and I imagine that the May revision will reflect changes, it's hard to say whether, caseload or adherence or reinfection rates will, create pressures in the opposite direction than we would like to see. So it's really hard to predict what the data will show, but, we'll update at May revision.
Any questions? Mr. Stone.
Thank you, Madam Chair. Going back to the $300 million that's been proposed, that equates to about 3,500 patients being treated statewide. I was curious what epidemiological studies you looked at that came to that conclusion that basically 0.009% of the state population is afflicted with Hep C, and I don't think the incidence of Hep C is going down. And I think that's also indicative of the education program that I think is not working well.
Yeah, so. I want to make it clear that, with respect to the clinical evidence that was evaluated, I definitely want to defer to departments. With respect to sort of the $300 million, though, the $300 million is not the only money that the state has budgeted for these treatments. So we have amounts that were appropriated in department budgets. And so we've got
basically a buffer fund, a buffer?
It's an amount that I think speaks to the fact that the amounts that we knew that we could budget for in each department budget was definitely insufficient. And I can speak to the Medi-Cal budget as something that I'm more familiar with than some of the other State Department budgets, was that we only reflected the amount that was going to be provided for kick payments to managed care plans for these drugs. We knew, though, that there was going to be fee-for-service costs in the fee-for-service side of the house, but that the trend data had not caught up with these new drugs that are in the pipeline because the trend data is a little bit older. That's why it's trended forward to predict future expenditures, and these drugs weren't kind of reflected in that older trend data. So we knew that we were shorting. We didn't know by how much, and we had very similar experiences in other state departments where they don't even budget. Their trend data didn't reflect those costs either, and they don't budget down to that line item to see here's what we think we're spending on this class of drugs. And so we knew that it was really, really difficult to get a good estimate in each department's budget, and that's why the set aside was needed to make sure that we weren't, creating deficiencies all across state government.
So at this point in time, have you been able to successfully get a committed rebate program from Sovaldi for their product at this point?
State departments are having better luck negotiating rebates right now with Sovaldi.
Okay, but we don't know what that rebate is, and it's not definitive yet.
Yeah, and
it's a work in progress.
So basically, there are rules around disclosing the exact amount of the rebate that you're getting. But there have been news reports that the Gilead has, reported that they're offering rebates that are
So it's fair to say
significant.
we are getting rebates, we're just not publicly allowed to disclose those for
The amount of the
commerce
specific,
issues.
yeah, the amount of the specific rebates, but we can disclose sort of like in globally how much we're getting in rebates.
And historically, do we have any evidence as to what the cost was to maintain a patient on medications prior to Sovaldi over the lifetime of their disease? Is it less than $85,000? Is it more than $85,000? In other words, will this drug ultimately save the state, a lot of money by having, number one, a cure and taking people off, Medi-Cal or public health systems to further the continuation of their therapies?
Yeah, so there's, and there has been research into this, and this kind of gets at why there's different utilization policies, depending on whether you're co-infected, whether you live in an institution or in the community, the level of how far your disease has progressed. All of these things, as you are well aware, sort of affect the type of treatment you might need in an inpatient setting. And so all of those factors sort of kind of affect a cost-benefit calculation. And so the various state departments have kind of done that work, and their medical personnel have done that work to kind of decide on a utilization management practice for these drugs, kind of taking in all those various factors.
And forgive my ignorance, is there any type of needle exchange program in the state of California at this time?
I'm not aware of a state-run program. I know that local jurisdictions.
Local jurisdictions,
There are 36 local programs operating.
So they do. So I guess my final comment is, number one, I applaud you for seeking rebates back from drug companies, and I think we are going to see more competition in this pharmacological realm of having a cure for Hep C. And competition, I think, is certainly good. But I really think we still need to focus a lot on education and how hepatitis C can be prevented, and that ultimately will, I think, come back in dividends to the state and saving us this type of horrific expense. So, thank you.
Mr. Monning.
Thank you. Just a quick follow-up on my colleague Senator Stone. I think it would also be useful. I know some of these funds are embedded in different departments and different programs, and we've asked you to justify the $300 million kind of buffer fund or umbrella. I think it would be helpful to have some estimates of the cost of not treating Hep C in particular, but with any high-cost pharmaceutical regime that is a high cost to the state and the taxpayer. I think it would be helpful for us to just even have an estimate of what is the cost prospectively if we don't take advantage of, with Hep C, for example, a treatment that offers, as I understand it, a cure. So while expensive to fund, are we saving double that, triple that? It was what Senator Stone was asking, and I don't expect that you have that at your fingertips. You alluded to some of the departments, including this, but I think it would be helpful for us in the legislature and helpful for taxpayers when they see these really large costs of a treatment program. What is the cost of not using that treatment? So just that would be helpful to us, even if it's a broad estimate. Are we saving tenfold, double the cost? Give us some indication on that. So if you could get that back to us, I think it would be helpful for all the stakeholders. Thank you.
And LAO Finance.
Amber DG, Legislative Analyst's Office. We find the administration's approach to budgeting the unallocated set-aside to be reasonable. However, we also find that there's considerable uncertainty at this time as to whether the amount of the proposed set-aside is appropriate, and we'll continue to look for additional information with regard to the cost to the state of these drugs, as well as potential utilization, and provide updates to the legislature as we receive that information. We also find that the proposed provisional budget language does not provide for sufficient legislative oversight, and we would recommend the language be modified to require notification to the legislature 30 days prior to the distribution of the funds of three things: the amount of the funds being distributed, the programs that will receive the funding, and the description of what the funds will be used for. We note that the administration has some concerns that the 30-day notification period may delay the funds getting out. However, the administration may request an expedited review, which would generally result in a quicker turnaround time and therefore reduce the delay in getting funds out while still allowing for sufficient legislative oversight.
Of course, Senator Monty.
So same question to LAO. Do you have any data that shows the cost of not investing in this treatment, long-term cost of non-treatment?
We have not done that analysis, but as we continue to look at what the cost of the new drugs will be, we can work with staff to provide additional information on that piece as well.
Thank you.
With that, we'll open up for public comment. Did you get the document you requested from them?
Thank you, Chairwoman Mitchell. My name is Christian Ramers. I'm the Assistant Medical Director for Special Populations at the Family Health Centers of San Diego and a Clinical Assistant Professor at UC San Diego School of Medicine. I'm an infectious disease specialist, and I work in a federally qualified health center where 95% of our patients are below twice federal poverty, so I feel uniquely qualified to comment on high-cost drugs and how they affect people living in poverty. You're going to hear later this morning about from several of my colleagues from CalHEP regarding prevention strategies, and I wanted to just discuss the strategic value of prevention strategies and let you know about some work we've been doing in San Diego. We received a CDC-funded grant in testing and linkage to care, and we've piloted it, and the funds are running out this year. But what we found in a year of testing is we did 1,600 tests in our community health centers as well as alcohol and drug rehab places. 20% of those tests were positive for 300 positive patients. 10% of those patients already had cirrhosis at the time of testing. And to your question about how much it costs, my read of the literature is that it costs about $50,000 to $75,000 a year to take care of somebody who has cirrhosis at the end of their liver disease stage. And it costs about $500,000 to do a transplant, which hepatitis C is the leading cause of transplants in the country. If we've learned anything from the HIV epidemic, from fighting it for 30 years, it's that early diagnosis, early linkage to care is cost effective and is going to be a key strategic element of prevention. So I'd urge you to consider the testimony later this morning from CalHEP regarding supplemental budget requests for prevention. Thank you.
Thank you.
Thank you very much. Next witness.
Good afternoon, Senators. My name is Emily Hirio. I'm the co-chair of the California Hepatitis Alliance, and I also work at Project Inform, which is an HIV and hepatitis C education and advocacy organization. And on the topic of the high-cost drugs work group, most importantly, we want to ensure that the voices of people impacted by conditions that necessitate high-cost drugs are a part of this process. I know that there's some discussion of including stakeholders outside of internal stakeholders in the near future, but we really want to emphasize that and make sure that it goes beyond, health plans and ensures the consumer voice is heard. We want to make sure that all high-cost drugs are addressed and not just hepatitis C drugs. There's a real opportunity here. There are drugs in the pipeline, that could potentially, in a few years, cure things like diabetes, and those are much larger populations than the hepatitis C population. So we want to make sure this opportunity is taken good advantage of and considered thoughtfully. We want to make sure that the issue of high-cost drugs is examined from a systems perspective, not just looking at cost containment, but strategies for paying for drugs. What are some, unique approaches California could take to purchasing? And we want to make sure, as you all have mentioned very eloquently, that the impact of public health is considered, that it's not just about curing individual people, but that by curing people, they avoid transmitting virus to others. And so that's thoughtfully considered. And, that there is potentially an opportunity to talk about prevention of hepatitis C, screening, linkage to care. And you will hear from us later on the Office of AIDS items about some proposals we have for the budget in that regard. And we want to make sure, lastly, that the outcome of this work group isn't a unified utilization policy for all of the departments. We think that DHCS serves a unique population. The state hospitals serve a unique population. ADAP certainly serves co-infected individuals who are at risk for higher, faster rates of liver disease than people who are mono-infected, and that there isn't one utilization policy sort of forced on all the state entities, but that each population is thoughtfully considered. Thank you very much.
Thank you. Next witness, please.
Good Good afternoon, Madam Chair and members. I'm Fred Notware. I represent Pharma. Just a couple of quick points. We really want to applaud the work of the administration. They've been very good to work with. They've reached out to us on a number of levels, both on the kick payment that was budget language last year, as well as going forward for the stakeholder process on the more global question of the high-cost drugs. The other point I wanted to make, that while it's still early and we're not quite there yet, the system is working. It's playing itself out in that negotiations are underway with manufacturers. The analysis correctly points out on page 18 that in the case of Sovaldi and Harvoni, there's now an agreement on the Medi-Cal fee-for-service side. I think that's in part because of competition. The other point to make, of course, is, and I think this was borne out by some of the earlier comments, the question is how many people are actually being treated, because the question about who gets treated is really appropriately being determined as we speak by the clinicians and the payer community itself. So while there are a lot of numbers out there, and with every number there's a real person in that position, I think, again, the system is determining the best way to approach these people with these very serious conditions. So my takeaway today, I think, is that for both the public and the private payer community, we're moving forward in the right direction. So we look forward to working with the committee, and thank you for your time.
Thank you very much for your testimony. Next witness.
Hello, my name is Farah McDade-Ting with the California State Association of Counties, representing all 58 of California's counties. I wanted to testify today to thank the administration and, of course, the legislature for their attention to this issue. CSAC is a member of the high-cost drug work group, and we appreciate the invitation. The state and counties have an interest in figuring out how to provide these drugs and medications for populations. We actually share populations. Someone may be on Medi-Cal and then enter the county jail system, or someone may be in the county indigent program and enter another system, or go from a healthcare plan to Medi-Cal. So we appreciate the acknowledgement of the interplay of all the populations that we serve, and we look forward to working on the working group with others. And as the working group may expand, we do believe that the health plans and providers and pharmaceutical companies also have a seat at the table. Thank you.
Thank you very much. Next witness, step up.
Linda Way with Western Center on Law and Poverty. We too are concerned with the high cost of Hep C drugs and its impact on access to treatment for low-income Californian consumers. Considering the disproportionate impact of Hep C on low-income consumers, we'd like the opportunity to be part of the work group.
Tam Ma with Health Access California, joining the chorus and urging the inclusion of consumer and patient advocates in the work group. We've expressed our strong interest to the administration and have also made suggestions on organizations that could be a part of this effort. Thank you.
Thank you.
Thank you, Madam Chair and members. Nick Luizos on behalf of the California Association of Health Plans. We're, as the payers in the healthcare system, or primary payers, both in commercial coverage and as a part of Medi-Cal, we're very interested in this $300 million set-aside. We think it's very significant, not just in terms of its size, but the fact that the state is reserving this amount of money for one drug or one set of drugs. There is no questioning the advancement in healthcare that are made with these products, but again, as payers in the system, we do have some concerns about the underlying pricing that is worrisome for both public programs and commercial coverage. We did hear, Madam Chair and members, in a state Senate hearing not too long ago that the makers of the hepatitis C drugs do not use the cost of development to price their products. We find that to be a bit curious and contrary to what the drug industry has been saying for years about why some of the products cost so much, and it's also a different standard than other sectors of the healthcare system are required to live under. We are very interested and encouraged by the fact that the state is making progress in their negotiations on rebates with the makers of these drugs. But we do want to point out this isn't just about Sovaldi. As an earlier witness testified, it's about the pipeline. 70% of the new FDA approvals in 2013 were specialty drugs, which tend to be higher on the price tag end. It's also expected that in 2015, 15 new blockbuster drugs will be entering the market, and so we have some concerns about how we are going to be paying for that in various sectors. We feel that the need needs to be on affordability, transparency to answer some of the outstanding questions, and we would suggest that the budget committees ask the LAO, in addition to the work that they're doing as a part of the May revise, the LAO or any other appropriate state entity to take a longer-term analysis of what these hepatitis C drugs may cost the state in the future. We agree with some of the earlier comments about how that number could change. It could change in either direction. You're right, Senator Stone, to say that about 3,500 lives, if you take the initial sticker price of Sovaldi, would be covered under the $300 million set-aside. But we've seen information suggesting that there are 600,000 Californians that have hepatitis C, and about 100,000 of those are in the state system in the various programs. I think the number's around 93, 95,000. So it may not be enough. So we're very concerned about this. And to both Senator Stone and Senator Monning's question, you made good points about the cost comparison of Sovaldi and Harmony to existing treatments. We do have some information from a couple of our health plans that might be helpful that I'd like to come in and talk to you about. But in essence, it's not a simple analysis of what the cost of the drug is between current forms of treatment. I'm not a clinician, but I understand from one of my health plans that only about 1% of current hepatitis C sufferers end up at a point where they need a liver transplant. So those costs are large, but a lot more people are eligible potentially to take Sovaldi and Harmony, so that needs to be part of the assumption as well. So in any case, thank you for your time.
Thank you very much. Next witness.
Chair and members, Kathy Mossberg, representing both the San Francisco AIDS Foundation and a member of the California HIV/AIDS and HIV&AIDS Alliance. We just want to associate our comments with our colleagues at CalHep, as well as just highlight a couple of pieces. We have reached out in regards to the stakeholder group as well. We think both certainly someone who can represent on Hep C side of things as well as HIV. Also agree that this is broader and will become broader than that. So obviously other groups you're going to have to be dealing with as things come into the pipeline. We also agree on utilization. That utilization criteria has very much stymied sort of who gets treated. And we do think that you don't get a one-size-fits-all. You can't take that approach. You do have to look at different populations for that purpose. And we also very much agree from doing decades of work in the HIV and AIDS world, that prevention is your better way to go long term. And so, as stated here before, folks will present some testimony on some budget augmentations that we'd like to put forward in that vein. So thank you for your time.
Thank you.
Aaron Fox from the Los Angeles LGBT Center. I would echo what my colleague just presented. We also believe that the stakeholder group that's being put together needs to be broader than just an internal group and have consumers and also harm reduction specialists who know the prevention side of this issue on that group. The center about 2 years ago took on a needle exchange program. It's in our parking lot 2 days a week now. It was located in Hollywood, and businesses in the neighborhood wanted it gone because they didn't want, especially their very VIP customers coming around and seeing a needle exchange outside of their business. And so the center agreed to partner with Clean Needles Now and have started a pilot project of trying to connect people who are using that service to our primary care clinic. And just out of the first 10 people that we've connected, there's been 3 previously undiagnosed positive Hep C tests. So we know that not only is prevention really crucial, but linking people through these programs with primary care and then also allowing them to access treatment is really the only way to go. So we appreciate the committee taking up this issue and more than happy to work with the committee further. Thank you.
Thank you.
Good morning, Craig Pulsper from AIDS Project Los Angeles. I just want to echo what my colleagues have said regarding the importance of prevention activities, particularly syringe access programs. These programs are important to prevent Hep C and also HIV and Hep B. So we urge the committee to consider proposals you hear later today to reinvest in these programs. Thank you.
Thank you. And we're going to hold that item open at this point.